Welcome to the Deep Dive, the show that's really engineered to give you that shortcut. Truly mastering complex information, turning huge amounts of data into, well, pure insight.
Exactly.
You know that feeling, right? That cough that just hangs around. Or maybe that low fever that won't quit. Or sometimes it's just a mystery illness. Doctors aren't quite sure. Today, we're diving deep, really deep into that microscopic world where some of the tiniest organisms cause some pretty big problems. And often, they're not what you'd expect at all.
That's absolutely our mission here. We want to give you that definitive shortcut so you can really master this nuanced world of infections. We're doing an exhaustive exploration, specifically of Mycoplasma infections,
Right.
All detailed in Chapter 188 of this comprehensive medical text we've got. The goal is simple. Pull out every single important nugget of knowledge, give you the most complete professional level picture possible.
So you feel like you're right there with the elite professionals in the field, yeah.
Precisely. Truly understanding these, invisible battles.
And when we say nuance, we really mean it. You're going to hit some real aha moments today because these organisms, well, they're fundamentally fascinating.
They really are.
They kind of challenge our basic understanding of bacteria, almost blurring the lines with viruses, don't they?
They do. And understanding why that is, their unique biology, that matters hugely for diagnosis and maybe even more importantly for treatment.
So, get ready to see these pathogens through a totally new lens. You'll be equipped with insights that, honestly, will make you feel like a seasoned expert by the end of this.
Okay, but before we jump straight into mycoplasmas, our source material actually kicks off with some really critical interconnected info on Q fever.
Oh, okay. A bit of a detour.
Sort of, but it's relevant. Chapter 188 is mainly mycoplasmas, yes, but this initial bit on Q fever really sets the stage. It highlights the wider complexities in managing infectious diseases, especially around long-term follow-up and prevention strategies.
Ah, I see.
It's actually a powerful illustration of the kind of deep vigilance some pathogens demand.
Right, and this is where that long-term strategic thinking really kicks in, isn't it? For chronic Q fever, especially in those high-risk patients.
Yeah, the ones who've had, say, 6 to 12 months of antibiotics, or people who are immunosuppressed, or maybe even those with untreated risk factors.
For them, the follow-up protocol is incredibly rigorous. We're talking serology, blood tests looking for antibodies, and PCR monitoring, which spots the bug's actual genetic material.
And get this, both of those tests done every 3 to 6 months for a full 2 years after the initial treatment finishes.
2 years after, wow.
Exactly. And it's not just post-treatment. Even during treatment for chronic Q fever, patients are checked every 3 months. You're looking at symptoms, any side effects from the drugs, and of course keeping an eye on the serology and PCR results.
Continuous vigilance.
Absolutely essential. And if there's even a hint of a new complication, repeat imaging, like scans, straight away to catch any changes. But here's what's really striking, and probably surprising for a lot of people listening. The pathogen can just persist. Relapse has actually been documented up to 5 years after treatment ended.
5 years later.
5 years. So that means monitoring both serology and PCR needs to continue for at least 5 years post-treatment. Minimum.
That's incredible.
It really is. It's a testament to how cunning, how resilient some of these pathogens can be. They demand this prolonged, almost intelligence-level watchfulness against them coming back.
5 years of follow-up for a bacterial infection.
Mm.
That's almost unheard of. It paints such a vivid picture, doesn't it, how persistent this thing is.
Mm-hmm.
So it's not just about hitting it hard with antibiotics up front. It's this long game of surveillance, like an ongoing intelligence op, because it can just pop back up years later if you drop your guard.
You got it.
But, okay, beyond managing it once it's there, prevention is obviously huge. And for Q fever, vaccination plays a big part.
It does. There's a whole cell vaccine, QVax, licensed in Australia, and it's been incredibly effective there. Led to dramatic drops in cases among abattoir workers, for instance, shows what targeted prevention can really do.
But it's not for everyone, right? There are restrictions.
Very important point. QVax is only given to people with no prior history of Q fever. And crucially, they need negative results in both serology testing and a special skin test.
A skin test, too.
Yeah, they do an intradermal injection of a diluted Coxiella burnetii vaccine that's the bug causing Q fever. It's a careful two-step screening process. You need to ensure safety and efficacy, avoid bad reactions in people who might already be immune or were exposed before.
Makes sense. And beyond vaccines, just good old-fashioned animal husbandry practices are key, aren't they? Especially since animals are a main source.
Absolutely paramount for stopping widespread environmental contamination by C. burnetii. We're talking specific actionable stuff here.
Like what?
Okay, so isolating aborting animals for up to 2 weeks, raising feed bunks so the feed doesn't get contaminated by, animal waste.
Right.
And the grim but necessary task of destroying aborted materials, burning and burying fetal membranes, stillborn animals. Got to stop the pathogen getting out there.
And protective gear, I assume.
Oh, yeah. Anyone handling potentially contaminated stuff must wear masks and gloves. It's a real reminder that public health stretches right onto the farm.
And these practices work.
They do. We've seen it. Take the big Q fever outbreak in the Netherlands. Combining widespread vaccination of sheep and goats with culling programs for infected animals, highly successful in controlling the spread.
And broader public health measures, like blood donations.
Good point. During a Q fever outbreak, and for 4 weeks after it officially stops, blood donations are just refused from anyone living in the affected area.
Okay.
It's a critical step to prevent potential transmission through blood products. Shows that multifaceted, rigorous approach to control that goes way beyond just treating sick people.
So Q fever really teaches us that some of these tiny invaders demand serious long-term thinking. From managing symptoms to preventing outbreaks, it really hammers home the chronic, persistent nature of some infections.
It certainly does.
Okay, so let's pivot now to something maybe even more elusive. Our main event, Chapter 188, introduces us to mycoplasmas. Organisms so unique, they almost defy definition, starting with a fundamental missing piece that just changes everything.
And here's where mycoplasmas really start to mess with expectations.
Yeah.
This is a major aha moment. They're prokaryotes, class molecules, and they are truly unique in the microbial world.
How so?
Well, their size, for starters, only 150 to 350 nanometers. That's actually closer to a virus than a typical bacterium. They're incredibly tiny.
Wait, microscopic, almost virus-sized. So how do we tell them apart? What's the key biological difference from viruses, which, need our cells to replicate?
That's the crucial point. Unlike viruses, which absolutely must hijack a host cell's machinery to reproduce, mycoplasmas are the smallest organisms capable of independent replication.
Independent.
Meaning they can actually grow in cell-free culture media. They don't need a living host cell to reproduce. That independence is a huge distinction.
Okay.
And speaking of unique, their genomes are tiny, among the smallest known. This genomic simplicity has big implications.
Like what?
Well, they lack genes for making amino acids, for fatty acid metabolism, for cholesterol. So they completely depend on a host for these essential nutrients.
Parasitic, basically.
Parasitic or saprophytic, yeah. Which means if you want to grow them in the lab, you need incredibly complex, fussy media. You have to mimic that rich environment they find inside a host.
And this leads us to their most defining feature, right? The ultimate aha moment.
Absolutely. The most paramount characteristic. Mycoplasmas completely lack a cell wall. None. Zip.
No cell wall at all. I always thought that was fundamental for bacteria, like their armor. So if that's missing, how does that change how we fight them? Does that mean things like penicillin are just useless?
You hit it exactly. That absence of a cell wall is the game changer. It directly explains why common antibiotics like beta-lactams, your penicillins, cephalosporins, anything targeting cell wall synthesis are completely inactive against them.
Yeah.
If there's no cell wall to target, those drugs just don't work. It's critical knowledge for any clinician. It immediately narrows your treatment options, stops you wasting time on ineffective therapy.
That is a huge red flag for doctors.
Yeah.
So how many of these cell wall-less wonders are actually living in humans? Our sources say at least 13 Mycoplasma species, 2 Acoloplasma, 2 Ureaplasma.
That's right. And surprisingly, most of those are just considered normal, harmless inhabitants, found on our oral and urogenital mucous membranes.
But not all of them are harmless bystanders.
Yeah,
right?
definitely not. And here's where we need to be specific. 5 species are conclusively pathogenic in people with normal immune systems.
Yeah.
Mycoplasma pneumonia, Mycoplasma hominis, Mycoplasma genitalium, Ureplasma ureolyticum, and Ureaplasma parvum.
Okay, 5 key players.
And they tend to stick to different areas. M. pneumonia mostly hits the respiratory tract, think walking pneumonia, whereas M. hominis, M. genitalium, U. uroloticum, and U. parvum are mainly linked to genitourinary tract problems and sometimes neonatal infections.
And other mycoplasmas.
They might cause trouble, but usually only in people who are immunocompromised.
All right, let's zoom right in on Mycoplasma pneumonia,
Right.
the classic culprit behind that atypical pneumonia. How does it actually cause damage? Its pathogenesis. It's pretty interesting.
It is. Generally, we think of it as an extracellular pathogen living and causing damage outside host cells. However, it has been shown it can survive and even replicate inside human cells.
Oh, really? Does that intracellular part matter much for the disease?
That's the thing. Its specific contribution to the overall disease isn't really well understood yet. It's an active area of research.
Okay, but what is known about how it works?
What is known, and it's quite fascinating, is its attachment mechanism. M. pneumonia has this complex structure at one end, a terminal organelle. Think of it like a specialized little foot.
A foot?
Sort of. It lets it attach really firmly to the ciliated cells lining our airways. It uses these intricate adhesins and accessory proteins clustered on that organelle like tiny grappling hooks.
Okay, so it latches on tight. Then what? How does it injure the tissue?
It does it in some surprisingly sophisticated ways. Primarily, it produces hydrogen peroxide, which is corrosive, and a specific ADP ribosylating and vacuolating cytotoxin.
Whoa, say that again?
ADP ribosylating and vacuolating cytotoxin. Basically, it's a chemical weapon that messes with the cell's internal machinery, makes it swell up, causes damage. And remarkably, this toxin is quite similar to the pertussis toxin.
The one that causes whooping cough.
The very same.
Wow. And this brings us back to that cell wall thing we talked about. No cell wall means no typical triggers for the immune system.
Exactly. Because they lack a cell wall, they also lack the usual stuff that kicks off the innate immune response. Things like lipopolysaccharide, lipoteichoic acid, murine fragments. They're just not there.
So it's like they're flying under the radar of some of our immune alarms.
In a way, yes. So how does the immune system react? Well, other parts step up. Lipoproteins from the Mycoplasma cell membrane seem to have inflammatory properties.
Oh.
They likely act through toll-like receptors, mostly TLR2, which are sensors on macrophages and other immune cells. These receptors recognize the mycoplasma and trigger inflammation.
And what does that inflammation look like in the lungs?
If you look at lung biopsies from patients, you see a distinct pattern. It involves the trachea, bronchioles, the tissue around the bronchioles. There's a significant monocytic infiltrate lots of specific white blood cells, monocytes, and lymphocytes, and also a luminal exudate of polymorphonuclear leukocytes. Basically, pus and inflammatory cells filling up in the airways. It's a specific kind of localized immune fight.
And the immune response itself, it's complicated, isn't it? This is where it gets really interesting, you said.
It's incredibly nuanced. Experimental evidence suggests our innate immunity, the body's quick first response, does most of the protecting in the lungs. But here's the twist, the critical nuance. Cellular immunity, the part using T cells to attack infected cells, might actually play an immunopathogenic role.
Meaning it makes things worse.
Potentially, yes. Instead of helping clear the infection, it might actually exacerbate the lung disease. Like the immune system overreacts and causes friendly fire damage.
That's wild. So some parts help, some might hinder.
It's a complex dance. On the flip side, humoral immunity, that's antibodies made by B cells, seems crucial for stopping the infection from spreading throughout the body. Dissemination.
How do we know that?
Because patients with humoral immunodeficiencies who can't make enough antibodies don't necessarily get worse lung disease initially, but they are much more prone to disseminated infections, severe things like arthritis, meningitis, osteomyelitis, far from the lungs.
Okay. That clearly shows the antibodies are key for containment.
Exactly. It highlights these specialized, sometimes contradictory roles of different immune branches. And in terms of lasting protection, severe M. pneumonia infections generally lead to stronger, longer-lasting immunity. Genuine second attacks of the pneumonia are pretty infrequent, suggesting a good long-term defense once you've fought off a bad case.
Right. So if you've had a really nasty bout, you're probably pretty well covered for a while.
Okay.
Let's talk spread. Where is this thing found and how does it get around?
It's worldwide. M. pneumonia is a global player in respiratory illness. What's often surprising, though, is that upper respiratory illness caused by it, like a bad cold or bronchitis, is probably up to 20 times more common than actual pneumonia.
20 times. So loads of people get infected with milder symptoms, but only a fraction develop the full pneumonia.
Exactly. It spreads efficiently person to person through respiratory droplets, coughing, close contact, and an estimated 80% of infections lead to clinically apparent disease, meaning most people who catch it will feel sick to some degree.
And the incubation period is long.
Quite long, yeah. 2 to 4 weeks. Which means outbreaks in communities or families tend to be slow burn affairs, stretching out over weeks. And we see high attack rates within families, maybe 84% in kids, 41% in adults. Shows how easily it spreads in close quarters.
And it causes these typical epidemics every few years.
Sporadic epidemics, yeah, roughly every 4 to 7 years, almost cyclical.
So what does this mean for community-acquired pneumonia, CAP, overall?
Well, M. pneumonia is a major cause of CAP, both in kids and adults. It's often lumped with chlamydia pneumonia and Legionella species as a key atypical bacterial cause.
Atypical meaning not the usual bacteria like strep pneuma.
Right. Different biology, often different presentation, different treatment. And in adults, M. pneumonia is actually the most frequently detected atypical bug causing CAP.
Got any numbers on that?
Yeah, an analysis of studies from 1996 to 2001 covering over 6,000 adults with CAP found M. pneumonia prevalence was a striking 22.7%.
Wow, nearly a quarter in that period.
Much higher than C. pneumonia, 11.7%, or Legionella, 4.7% back then. But interestingly, more recent studies from 2002 to 2015 found a shift. A significant drop. M. pneumonia prevalence down to 7.2%. C. pneumonia also down to 4.3%. Legionella to 2.8%.
Huh. So what's going on there? Why the change?
That's the big question for infectious disease folks. Could be changes in how we diagnose things. Maybe we're better at finding other causes now. Or maybe changes in our immunity. Or maybe even subtle changes in the bug itself affecting how common or severe it is. It's a dynamic picture.
Yeah, fascinating. Reminds us this stuff is always evolving. And historically, it had other names too, right?
It did. Eaton agent pneumonia, after Monroe Eaton, who first isolated it back in the 40s. Also, primary atypical pneumonia, and that common one, walking pneumonia.
Because you're often not sick enough to be stuck in bed, even with pneumonia on an x-ray.
Exactly. You're walking around feeling rough, but still mobile.
Okay, so clinically, what does it actually look like when someone gets sick?
Acute infections usually show up as upper respiratory tract infections. Could be pharyngitis, sore throat, or tracheobronchitis, inflammation of the windpipe, and bronchi.
Wheezing too?
Yeah, it can cause reactive airway disease or wheezing, or sometimes just a general non-specific upper respiratory thing. Now, interestingly, there's this common idea it causes ear infections, otitis media, sometimes with those nasty blisters on the eardrum, bullous myringitis.
I've heard that. Is it true?
Well, our sources say there's actually little conclusive evidence to support M. pneumonia being a major player in otitis media.
Good to know. Debunking myths. So how often does it actually become pneumonia?
Only in about 3 to 13% of people who get infected. The onset is usually gradual over days, but sometimes it can hit more suddenly.
Symptoms.
Sore throat might kick it off, but the most common symptom is definitely cough. Usually non-productive, dry, but sometimes people do cough stuff up. Headache, feeling generally unwell, malaise, chills, fever, also very common.
And what about listening to the lungs?
On exam, you'll hear wheezes or rails, those crackly sounds, in about 80% of patients who actually have the pneumonia. But often, you really need that chest x-ray to confirm it.
And what does the x-ray typically show?
The most common pattern is parabronchial pneumonia. That means thickened bronchial markings, streaks of interstitial infiltration, kind of hazy lines, and maybe some small collapsed lung areas, subsegmental atelectasis.
Can it look like regular bacterial pneumonia sometimes? Like a whole lobe filled?
It can, yeah. Segmental or lobar consolidation isn't uncommon, which can definitely mimic the more typical bacterial pneumonias.
Fluid around the lungs, pleural effusions.
Clinically obvious ones are rare, don't usually cause symptoms. But if you do special x-rays, lying the patient on their side, lateral decubitus views up to 20% actually show some small effusions, a subtle sign of inflammation.
Okay, but here's the crucial point you made earlier, right? Just looking at the patient, listening to their chest, even the x-ray, you can't reliably tell if it's M. pneumonia or something else.
Exactly. The clinical presentation alone is just not useful for differentiating it from other types of COP. You simply can't tell for sure just by the symptoms or basic exam.
And this leads to that key diagnostic clue.
The vital, practical takeaway for clinicians. If someone has community-acquired pneumonia and they're not getting better on penicillin or cephalosporin,
Yeah.
then M. pneumoniae infection deserves serious consideration immediately because, remember,
No cell wall. Those antibiotics don't work.
precisely, it's a massive red flag. If standard antibiotics fail, think Mycoplasma.
Huge clinical alert. Okay, so what's a typical course? Prognosis.
Symptoms usually clear up on their own within 2 to 3 weeks, generally self-limited. But, and this is important, appropriate antibiotic therapy significantly shortens how long someone is sick.
It really makes a difference then.
Definitely.
Yeah.
Randomized, double-blind, placebo-controlled trials in adults clearly show treatment cuts down the duration of fever, cough, feeling unwell, how long you're hospitalized, and even helps the X-ray abnormalities clear up faster.
Does it ever cause long-term issues?
Sometimes, yeah. Some patients might get recurrent wheezing or reactive airway disease after the pneumonia clears. And the whole question of chronic infection, especially maybe linking to asthma that's still being actively investigated, raises another important question, doesn't it? Could this seemingly short-term infection have longer echoes for lung health?
Yeah. And it can be serious, right? Even fatal.
Uncommonly, it can lead to critical illness and very rarely, yes, even death.
Okay, beyond the lungs.
Yeah.
It can cause problems elsewhere too. Extrapulmonary manifestations.
Oh, yes. A surprising, often significant array of effects beyond the lungs. They're uncommon, given how often people get the respiratory infection, but when they happen, they can be quite serious.
How does this happen?
Couple ways. Could be direct disseminated infection, where the bug itself spreads, especially in people with those humoral immunodeficiencies we talked about. That can cause things like septic arthritis, bacteria right in the joint. Or it could be post-infectious autoimmune phenomena. The immune system gets triggered by the infection and then mistakenly attacks the body's own tissues. Think Guillain-Barré syndrome.
Right.
Or maybe it's linked to that ADP ribosylating toxin we mentioned earlier.
And here's the really tricky part you mentioned. Often these patients don't even have lung symptoms.
That's what's fascinating and a huge diagnostic challenge. Many patients with extrapulmonary disease from M. pneumonia have no respiratory symptoms. The systemic effects just appear out of the blue. Imagine someone presenting with weird neurological issues, and the culprit, Mycoplasma, caused no cough at all.
Mind-boggling. Makes diagnosis so hard. What about skin problems?
A whole variety of rashes reported. Red ones, erythematous, which can be flat spots, macular or raised bumps, maculopapular. Blisters, vesicular or bigger bullous ones. Tiny red spots from bleeding under the skin, petechial. Hives, urticarial.
How common are rashes?
Some reports say maybe 17% of patients with the pneumonia get a skin eruption, but the most clinically significant one, erythema multiforme major, also known as Stevens-Johnson syndrome.
That's serious.
Very serious. A potentially life-threatening reaction involving skin and mucous membranes. And it seems to happen more often with M. pneumonia than with many other infections. A critical thing to consider.
And neurologic problems. Sounds like a wide range there too.
An incredibly wide spectrum. Most common are meningoencephalitis, inflammation of the brain, and its linings, encephalitis itself, brain inflammation, Guillain-Barré syndrome, and aseptic meningitis.
Wow. How often is it implicated in encephalitis?
It's thought to be the likely cause in maybe 5 to 7% of encephalitis cases. That's a significant chunk of those serious conditions.
And other neuro issues.
Yep. Cranial nerve problems, acute psychosis, problems with coordination, cerebellar ataxia, widespread nerve inflammation, acute demyelinating encephalomyelitis or EDEM, stroke-like events, cerebrovascular thromboembolic events, spinal cord inflammation, transverse myelitis. It really underscores how it can hit diverse critical systems, and it doesn't stop there. Hematologic blood-related issues can include red blood cell destruction, hemolytic anemia, bone marrow failure, aplastic anemia, those weird cold agglutinins that clump red cells in the cold, serious clotting problems like disseminated intravascular coagulation, DIC, or just a general increased tendency to clot, hypercoagulopathy.
When does the anemia usually show up?
Generally in the 2nd or 3rd week of illness, adding another layer of complexity.
Good grief. Any other organs?
Our source convincingly links M. pneumonia to hepatitis, liver, glomerulonephritis, kidneys, pancreatitis, pericarditis, heart muscle, pericarditis, sac around the heart, rhabdomyolysis, muscle breakdown, and arthritis.
Both kinds of arthritis.
Yeah.
Septic and reactive.
Both. Septic, with the bug in the joint, and reactive, where it's an immune response. And that septic arthritis, seen most often in those hypogammaglobulinemic patients, the ones low on antibodies, ties right back to humoral immunity stopping spread.
So with all these potential presentations, how on earth do you diagnose this thing? especially if symptoms are misleading.
Exactly. It's tricky, and why understanding the biology is key. Let's reiterate, clinical findings alone, standard lab tests, even the chest x-ray, not useful for reliably telling pneumonia apart from other CTs.
Can't rely on just symptoms or a basic X-ray.
Nope. And crucially, remember, no cell wall. Invisible on a gram stain. That quick bacterial check won't find it.
What about that old cold agglutinin test?
Yeah, historically interesting, but measuring cold agglutinin titers is no longer recommended. Findings are nonspecific, and thankfully we have much better, more specific tests now.
Okay, so what are the recommended methods, the tools the pros use? Our source has a playbook, right?
It does. Top choice for accuracy. Polymerase chain reaction, PCR. Detecting the organism's genetic material in respiratory secretions.
How good is PCR?
Impressive. Sensitivity around 65 to 90%, specificity 90 to 100%. Big advantage. Speed, you get a rapid, specific diagnosis much earlier in the illness. Critical for treatment decisions.
What kind of samples? Throat swabs, sputum?
Oropharyngeal, nasopharyngeal, pulmonary specimens, all good for diagnosing the pneumonia. And if you suspect it's causing problems elsewhere, like meningitis, you can test other fluids, like CSF, using PCR too.
What about culture? Growing it in the lab?
Culture is 100% specific. If you grow it, it's definitely there, but the sensitivity is frustratingly low, 60% or less.
Why so low?
Needs special, rich media, takes weeks to grow, often hard to actually isolate from clinical samples. So for routine diagnosis, culture is not recommended, mainly for research or specialized resistance testing.
Okay, so PCR good, culture tricky. What about blood tests for antibodies, serology?
Serologic studies, looking for IgM and IgG antibodies the body makes, are also used. Sensitivity and specificity vary, maybe 55 to 100%. The recommended method is a ELISA enzyme-linked immunoassay.
But there's a catch with serology, isn't there?
A critical catch. You absolutely need paired samples. One taken early in the illness, acute phase, and another taken a few weeks later, convalescent phase.
Why paired? Why isn't one enough?
Because antibodies might not show up until 2 weeks into the illness, so that first sample might be negative even if you have the infection. You need the second sample to see a significant rise in antibodies, confirming a recent infection.
Ah, I see.
Plus, IgM antibodies can hang around for up to a year after infection, so just finding IgM might mean a recent infection, not necessarily the acute one causing symptoms right now. You have to be smart interpreting these.
So PCR for speed and early detection, paired serology for confirmation later.
Yeah.
What's the best overall approach?
The combination. Using PCR on respiratory secretions and doing paired serologic testing is considered the most sensitive and rapid approach overall. Gives you the most complete, timely picture.
And if you suspect resistance to antibiotics?
Then resistance testing using culture or specialized PCR is available through reference labs. Especially important if you suspect macrolide resistance, which we need to talk about next.
Right, so you finally diagnosed it. How do you treat this elusive bug?
Okay, treatment. While most untreated cases resolve in 2-3 weeks, it can be serious, and it definitely responds well to the right antibiotics. Those randomized trials showed treatment significantly shortens the illness, less fever, cough, malaise, shorter hospital stays, faster X-ray clearing. It helps.
So what are the go-to drugs?
Primary choices, listed in our source. Macrolides. Like oral azithromycin, often 500 milligrams day 1, then 250 milligrams daily for days 2 to 5. Tetracyclines, like oral doxycycline, 100 milligrams twice daily for 7 to 14 days, and respiratory fluoroquinolones.
Any specific ones to avoid?
Yes, vital note for clinicians. Ciprofloxacin and ofloxacin are specifically not recommended. They just don't work well against pneumonia, high resistance levels in lab tests, poor performance in studies.
Okay, good to know. How long is treatment usually?
For the quinolones, a 7 to 14-day course seems adequate.
Do you need to test afterwards to make sure it's gone, like a test of cure?
Actually, no. Here's another counterintuitive point. Even the right antibiotics, which clearly help symptoms, don't seem to shorten how long you can detect the organism by PCR or culture. So testing again afterwards isn't generally suggested. You treat the disease, the symptoms, not just the presence of the bug.
Okay, now about that resistance, particularly to macrolides.
Yes. This is where it gets really interesting and concerning for future treatment. Macrolide resistance is a growing global problem.
Where is it worst?
Very high levels reported in Japan and China, up to 90% or even more in some areas. It's also emerging in Europe and maybe to a lesser extent so far in the U.S.
What about the U.S. numbers?
National surveillance from 2018 found about 10.2% of U.S. isolates were macrolide resistant. but it varies a lot by region.
How so?
Between 2015 and 2018, resistance rates were much higher, 15.2% to 21.7% in the eastern U.S., compared to only 1.9% to 2.8% in the western U.S. So what works reliably in California might be less effective in New York.
And this resistance actually matters clinically. It's not just a lab finding.
Oh, absolutely matters. Studies clearly show patients with macrolide-resistant M. pneumonia who get treated with macrolides have significantly longer symptoms. Fever, cough last longer compared to those with sensitive strains.
So longer illness, more potential complications.
Exactly. So the takeaway: if macrolide resistance is known to be high in your area, or if you strongly suspect it in a patient who isn't improving on a macrolide, you should seriously consider using a non-macrolide antibiotic first, like doxycycline or a respiratory fluoroquinolone. And you can send a sample to a reference lab to test for resistance, which can guide treatment if needed.
What about steroids, corticosteroids? Any role there?
It's a nuanced area, still evolving. The official 2019 guidelines from IDSISETS don't routinely recommend steroids for general community-acquired pneumonia. However, some clinical literature suggests adding glucocorticoids might be valuable for severe or refractory M. pneumonia, the really tough or aggressive cases.
Any solid evidence?
A 2019 meta-analysis in kids looked at 24 randomized trials. It found steroids significantly reduced hospital days and fever duration in cases that were macrolide refractory, where macrolides weren't working.
What about adults?
Data's more limited, mostly observational studies, but they also suggest a potential benefit. It kind of hints back to that immune overreaction, the immunopathogenic part we discussed. Maybe steroids help dampen that harmful inflammation.
And for the really bad neurologic complications, like encephalitis, do we know what works best there? Antibiotics, steroids, IVIG?
That's the problem. For neurologic disease specifically, the roles of antimicrobials, steroids, and IVIG intravenous immunoglobulin are still largely unknown. It raises a huge question for ongoing research. How do we best treat these most severe, potentially life-altering complications?
Okay, shifting gears a bit. Let's talk about the other key group, the urogenital mycoplasmas.
Right. So Mycoplasma hominis, Mycoplasma genitalium, ureaplasma ureolyticum, and ureaplasma parvum. These can all cause urogenital tract disease.
But if you find them elsewhere in the body,
then their significance is often unknown, still under investigation. Like Mycoplasma fermentans hasn't really been convincingly shown to cause human disease.
how do these urogenital ones spread?
Primarily sexual contact. The risk of just carrying them colonization goes way up with more partners. But they can also be passed from mom to baby during birth, causing neonatal infections.
And they're common, especially in women.
Highly prevalent in asymptomatic women, all through the lower urogenital tract. Most found in the vagina, then periurethral area, cervix. Ureaplasmas are found less often in urine than the cervix. M. hominis is about equally common in both spots.
Got any numbers? How common are we talking?
Get this. Ureaplasmas are found in the vagina of 40 to 80% of sexually active asymptomatic women. M. hominis in 21 to 70%.
Wow, huge ranges, but very common.
And often found together, concurrently present in 31 to 60% of women. In men, colonization is generally less common, found in urine, semen, distal urethra of asymptomatic guys.
Which highlights that paradox again, right? They're so common. So when are they just hanging out versus causing actual problems?
Precisely. That's the core question, which leads us to their clinical manifestations, what diseases they actually cause. And here's where the paradox gets clearer.
Okay, like urethritis, urethral inflammation.
Yes. Ureaplasmas, especially ureolyticum, might cause many cases of chlamydia-negative non-gonococcal urethritis NGU, where you rule out chlamydia and gonorrhea. They might also cause chronic voiding symptoms in women.
But what about all the asymptomatic men carrying them?
That's the paradox. It suggests maybe only certain genetic types, serovars, are pathogenic, or maybe you need predisposing factors like a weakened immune system or lack of prior immunity, or maybe disease only happens on first exposure. We don't fully know. Ureaplasmas are also implicated in epididymitis, testicular tube inflammation.
What about M. genitalium?
M. genitalium also clearly causes urethritis in men and women, increasingly recognized as an important STI.
Do they cause prostatitis?
No, neither M. genitalium nor ureaplasmas seem to have a role in prostatitis, and M. hominis doesn't seem to be a primary cause of urethritis, epididymitis, or prostatitis either.
Okay. What about kidney infections? pyelonephritis.
Evidence suggests M. homines causes up to 5% of acute pyelonephritis cases, so a significant minority cause. Uriplasmas, though, not associated with kidney infection.
Kidney stones, urinary calculi.
Uriplasma seem to play a limited role, but we don't really know how often they reach the kidney, what predisposes people, or how common they are compared to other stone-forming bugs.
Pelvic inflammatory disease.
PID.
Hominids can definitely cause PID. That's serious infection in female reproductive organs. Often it's part of a mix of bacteria polymicrobial, but it can act alone in some cases.
And M. genitalium.
Also strongly associated with PID, a significant contributor. But here's a key distinction. Ureaplasmas are not thought to cause PID, despite being common down there.
Infections after childbirth or abortion.
Hominids is implicated as the main pathogen in about 5 to 10% of women with postpartum or post-abortal fever infection. Ureaplasmas maybe to a lesser degree.
Do these need treatment?
They're often self-limited, go away on their own, but if symptoms persist, definitely treat with antibiotics to prevent progression. Ureaplasmas also seem to play a role in some post-C-section wound infections.
Can they cause infections outside the urogenital tract, like M. pneumonia does?
Rarely, yes. M. hominids can cause brain abscesses, wound infections, infection after heart surgery, post-sternotomy mediastinitis, endocarditis, neonatal meningitis, usually in vulnerable people, though.
Immunocompromised. Exactly. Immunocompromised and hypogammaglobulinemic patients, those low on antibodies. Again, shows the protective role of humoral immunity. Both ureaplasmas and M. hominids can cause septic arthritis in immunodeficient patients, too.
What about newborns?
Ureaplasmas probably cause neonatal pneumonitis, lung inflammation in newborns, and their possible role in bronchopulmonary dysplasia, that chronic lung disease in preemies, is still being actively investigated. No conclusive evidence yet, though.
Which really underlines the ongoing discovery, right? Still so many unanswered questions.
Absolutely. Like whether ureaplasmas and M. hominids cause infertility, miscarriage, premature labor, low birth weight, or inflammation of the fetal membranes, chorioamnionitis, all active areas of research. Shows how much we're still learning about these seemingly common bugs.
So how do you diagnose these urogenital ones, given they're often just there?
Well, both culture and PCR can isolate them. But culture is challenging, needs those special techniques, and media usually only found in big centers or reference labs. Not easy for routine clinics.
And antibody tests. Serology.
Critically, unlike M. pneumonia, serologic testing is not recommended for diagnosing urogenital mycoplasma infections. Antibody levels just don't reliably tell you if it's colonization versus active disease.
Okay, so finally, treatment. If you find them, do you always treat?
Generally, no. Because colonization is so common, just finding them in the urogenital tract without disease symptoms does not usually warrant treatment.
That's a huge difference from M. pneumonia.
Massive difference. For urogenital mycoplasmas, you treat the disease, not just the presence of the organism. Find them incidentally in someone asymptomatic. Usually leave them alone.
Okay, but if there is disease, what are the treatments?
Right, if symptomatic. For ureaplasma infections, macrolides like azithromycin and doxycycline are the drugs of choice. But, like M. pneumonia, resistance is reported to macrolides, doxycycline, quinolones, even chloramphenicol. Susceptibility testing can be important.
What about M. hominids?
Hominids is naturally resistant to macrolides, so doxycycline is generally the go-to, though resistance is reported there too. Clindamycin is usually active. Quinolones show activity in the lab.
And M. genitalium, that STI one.
For M. genitalium, the initial choice is usually azithromycin, often a single high dose. But again, resistance is a growing worry.
So if azithromycin fails,
then moxifloxacin, a different type of quinolone, has been successfully used as second-line treatment. Really shows how clinicians have to adapt treatment strategies as these bugs keep evolving resistance.
Wow. That was an incredibly deep dive into mycoplasmas, really unpacking their unique biology, all those different ways they show up, the diagnosis, the treatment challenges.
It's a lot, isn't it? But our source material actually flows right into the next fascinating group, Chapter 189, setting us up for future dives and showing how interconnected these things are. Chlamydial infections.
Chlamydia. Equally compelling, but different again.
Yeah.
They're obligate intracellular bacteria, right? Meaning they have to live inside our cells, kind of like viruses in that sense.
Exactly like viruses in that regard. But, as we'll see, they have their own unique bacterial traits. They cause a huge range of diseases in humans and animals. Another example of pathogens with their own biological quirks.
How are they classified now? I remember hearing it changed.
It did. Originally, just 4 species in the Chlamydia genus. C. trachomatis, C. pneumonia, C. cetaceae, and C. pecorum, mostly in animals. but science marches on.
So what's the new setup?
The C. cetacea group got split into three. C. cetacea itself, from birds, causes psittacosis in humans. C. felis, from cats, causes conjunctivitis. And C. abortus, causes abortion in livestock. And the mouse strain is now C. miradarum. The guinea pig one is C. caviae. Reflects a better understanding of their genetics and who they infect.
And C. trichomonas itself has different types. Biovars.
Two main biovars, the trachoma biovar and the LGV biovar lymphogranuloma venereum.
Trachoma biovar causes.
Two big things in humans. Ocular trachoma, tragically, the leading infectious cause of preventable blindness globally and urogenital infections, mostly sexually transmitted but can pass from mom to baby at birth.
And the LGV biovar.
That's linked to specific serovars, L1 to L3, causes a more invasive systemic STI with different symptoms.
Does knowing the specific serovar matter for treatment?
Usually not. Here's a vital practical point. While you can tell the serovars apart with fancy tests, their antibiotic susceptibility is generally the same. They respond to the same drugs.
But there's an exception.
The one crucial exception is LGV. If you suspect LGV clinically, then figuring out the serovar is important. Why? Because LGV strains need a significantly longer course of treatment compared to other C. trachomatis infections. That's where the nuance directly impacts patient care.
Got it. Longer treatment for LGV. Okay, and just briefly, their basic biology. Unique growth cycle.
Fundamentally, they're non-motile, gram-negative, obligate intracellular bacteria. Replicate only inside the host cell cytoplasm, and they form these characteristic membrane-bound intracytoplasmic inclusions, little factories inside the cell.
Can you see those?
Yeah, they're actually the basis for some diagnostic tests visible under a microscope. And what's fascinating, again refining classification, is that although they were first thought of as large viruses because they had to be inside cells,
They're not viruses.
not at all. They have both RNA and DNA, and they have a cell wall structurally similar to other gram-negative bacteria, even though it lacks the usual peptidoglycan. It uses unique disulfide bonds for strength instead. They really are a bridge between worlds.
And that unique growth cycle. Two forms.
Exactly. A hallmark of chlamydia. Amazing adaptation. They alternate between two specialized forms, like a two-stage life cycle.
What are they?
First, the elementary body, or EB. That's the infectious form. It's adapted for extracellular survival. Tough, dormant, can exist outside a cell, ready to infect.
Okay, the tough traveler.
Right. Then, once it infects a cell, it transforms into the reticulate body, or RB. This is the metabolically active replicating form. But it's non-infectious and adapted only for the intracellular environment inside that inclusion.
So the RB grows and divides inside the cell.
Repeatedly, filling up that inclusion. Then, after many rounds of replication, these RBs reorganize, condense back into new, tough EBs.
Yeah, man.
Then they're released from the cell to go infect new cells. It's a brilliant, efficient two-stage cycle, ensures survival, spread, and makes them tricky targets for drugs, which need to get inside the cell and potentially act on different stages.
Wow. So what an incredible journey today. Started with that long-term vigilance for Q fever,
Yeah.
plunged into the truly unique world of mycoplasmas, pneumoniae, the urogenital ones, and even got a glimpse of chlamydia's fascinating two-stage life.
We covered a lot of ground,
Yeah.
and the mission was to give you that comprehensive professional-level understanding. We've really highlighted how the pathology, diagnosis, treatment, it's all interconnected. Knowing the biology, like no cell wall or that unique growth cycle, directly tells you how to approach them.
Yeah, you feel like you have the details now, the specific knowledge, how it all links together, enough to really master this, not just memorize facts.
That's the goal.
So what does this all mean for you, listening in? Well, next time you hear about an atypical infection, or maybe wonder why a certain antibiotic isn't working, think about these invisible, intricate battles happening at the cellular level.
Absolutely. And what other microscopic mysteries might be shaping our health in ways we're only just starting to truly grasp? How do these tiny biological nuances influence real-world clinical decisions, public health strategies? The deeper you dive, honestly, the more astonishing this microbial world becomes.
Until next time, keep diving deep